My name is Jan Flugel. I have the pleasure and the honor of introducing our guest speaker, Dr. Roger Smith, today. I've known Dr. Roger Smith as a patient, and I've had an excellent experience undergoing his kyphoplasty and vertebroplasty procedure. And when he saw me, he said to me something that stuck with me and made me believe that this is something we have to, help promote, and we had to get him here as a speaker. He told me that when he sees patients and he sees that they're bent over like this, it's too late to help them, and that's very frustrating. Early on, though, it's often possible to help them through the procedures that his clinic and kyphoplasty and vertebroplasty clinics can offer. Dr. Smith is a neuroradiologist and assistant professor in the departments of medical imaging and neurosurgery at the University Health Network, which includes Toronto Western Hospital and Toronto General Hospital and Princess Margaret Hospital. He's also the co-director of the multidisciplinary now metastatic spine clinic. He's specially trained in neurosurgery with fellowship training in diagnostic neuroradiology and interventional spine radiology. He's done in excess of 1,500 vertebral augmentation procedures, and 96% of them have been for metastatic cancer, including myeloma. He does a lot of myeloma work. In addition, he performs image-guided needle procedures for pain, and he's really a pioneer in integrating new techniques in basically managing complex sacral and vertebral fractures in cancer as well as osteoporosis. He was instrumental in developing the procedures with Cancer Care Ontario and obtaining funding for them, because that was initially a problem. Back when I was diagnosed 12 years ago or so, I don't think it was funded. And I do remember the first time Dr. Smith came and spoke to us in 2017. I sat in the audience and I thought to myself, well, I have bone lesions. Maybe I'll be seeing Dr. Smith one day. And sure enough, I did. And also, at the time, I think it was questionable as to whether there was OHIP funding, but there is now. And it's clearly something that is becoming mainstream. His current project is the formation of the multidisciplinary metastatic spine clinic, and it's a collaborative practice with oncology, spine surgery, and interventional neuroradiology. So that is quite a set of tertiary specialists that deliver this very focused capability, and something that we should understand and value as myeloma patients very much. So with all that, I'm happy to have Dr. Smith come up and give us his presentation. And
thank you very much. Those are very kind words. Thank you. And thank you for inviting me. Now, we're supposed to start off with a sort of a funny story. So Suzanne gave me the intro for a story when she started working in tobacco stripping. And my godfather was a tobacco buyer in southwestern Ontario. And I don't know if they ever crossed paths, because I don't know when she was doing her tobacco job. But he was there pretty much from, shall we say, the late 40s through until the early 90s when he demised. But he was mainly instrumental in getting rid of tobacco in southwestern Ontario, because he saw the writing on the wall and realized that tobacco was not going to be a mainstay product any longer. And he spent the last part of his working life going around trying to encourage farmers to move into other high cash crops, and ginseng was one of the things that he'd recommended over the years. He was diagnosed with Parkinson the day he retired, and so he wasn't able to travel and do all the things that he'd put off until retirement because of another, shall we say, chronic disease. Anyway, so I'm going to sort of introduce it. I like to speak very informally I don't mind being interrupted. I don't mind if you want to save the questions till the end, if you have any questions, however you want to do it. So I've got, as I say, I've got the presentation, and if there are things that you want me to try and expand on, I can do that. You have to keep track of the time because we can get carried away as we go along. So we're going to sort of start off, and I suppose I should say there are some disclosures. I consult to Medtronic and to Stryker. Both companies provide equipment that I use. I chair the Kyphoplasty and Vertebroplasty Working Group for Cancer Care Ontario, and that was responsible for raising the funding. And I still work with them on the Interventional Oncology Steering Committee, Cancer Care. And I suppose I'm part of the Multidisciplinary Metastatic Spine Clinic as a co-director, but there are no commercial interests in terms of that. We've got a few objectives. We'll try and give you a view of what we see and looking for in multiple myeloma. We're going to mention something about pain, look at some of the different diseases as they present, run through the procedures, and show you what's happened. If you go to, I mean, this is the boring part because there are very few images that go with it. But if you look at the go to the statistics that are out there, and these are just taken from Cancer Care and from Cancer Care Ontario as well. The number of cases per annum is about 4,000 new patients per annum across the country. And that's, as I say, the incidence rate of 10.9 per 100,000, and 5.4 males and 6.4 for females. So what I think is really interesting is that compared to other cancers, the incidence rate of myelomas has increased the most. We're looking at a 2.5% per year, but it's cumulative over time, and in fact this is a fairly large increase based on that. All right, so we're looking at 23 percentage points survival over time. Myelomas, people are surviving more with it. The 5-year survival has improved, and when I was in Kingston before I came back to Toronto, one of the oncologists was diagnosed with myeloma, and everybody went into a sort of a depression in the department because this was in the mid to late 90s, and because survival for myeloma was so short that they thought, you know, that's it, it's a death sentence in terms of it. Well, I treated him about 5 or 6 years ago, so he was certainly 20 years on from the diagnosis, nearly 30 years on from the diagnosis, well into his retirement. But there've been huge strides in terms of progress in the management. And as my hematology colleagues say, it's not about managing the disease; it's about managing the sort of the recurrences, and keeping everybody and keeping moving. And the tools that are available have become greater over time. So, I mean, we're really looking at a lot of people that are diagnosed, and that's really the message in the statistics at the end of it. Sorry, I just got to keep an eye. I can't feel anything on the right hand, on part of my finger because I cut the nerve some years ago. But if I miss the thing, I can feel on the outside of the finger, but not the inside of the finger. That's a story in itself. So this is, but we're looking at males and females are pretty much equal in the province, and we can see that there's a big spike coming in this 45, in this mid range now. We're seeing younger people with myeloma than we did previously. Oops, where have we gone? There. This is really just showing the same things in a different form, and then we have some graphs. Again, all of these are online. Oops, I'm not doing that. Here we go. The myeloma one is the second up from the bottom. It's hard to see from here. I think it's a little triangle, but you can see that there's been this uptick in a lot of cancers, and myeloma is obviously in that and in that group as we go forward. I'm going to stand here because I can't, it's too small to read over there. It's associated, I mean, myeloma is associated with the greatest symptomatic burden of almost, and effect on quality of life of any cancer. It's extraordinary how it affects people. And it presents with bone disease, pain, fatigue, renal insufficiency, metabolic abnormalities. And I think that the message that comes through, because we've got this improved survival, is trying to, in terms of active management and stem cell transplants, the key to improved myeloma care is really prevention, early detection, and prompt management of the complications that occur. And it's this prompt management of certainly of fractures, cord compression, and paraplegia. And then if not properly addressed, these go on to form chronic comorbidities and chronic symptomatology that can affect how people are. And it is exactly as Jan was saying. And it's not a disease that you set it and forget it. It keeps going. And so the team that is built up around you and is part of your life for a period of time becomes very important. Sorry, this is just how it came up. It's in it. Yeah. Okay. So this prompt management. There we go. But if we look at this graph here, this is myeloma, the bottom line. You can see that it really is responding well to treatment. We go back into the 90s. This is your relative survival, and then as we've gone, it amongst all of the cancers has taken a huge jump, and it's really improved. How do you make the diagnosis? And this I think is one of the key things with myeloma, and I can't speak to it. Everybody in the room has had contact with myeloma. They know what myeloma is. I see dozens of cases a week with myeloma. It's the teams I work with see myeloma, and it seems not a difficult diagnosis when you're working with it all the time. But when you dilute it out into family medicine, into primary health care, out in the community, they see a lot more people with benign backache, back pain, and other things than they see with myeloma. And the symptoms are, generally speaking, relatively innocuous. Back pain, bone pain, rib fractures. Those, when you put them together, that's not a normal complex. That's not your weekend warrior who's just been putting nails in the roof and climbs down on Monday morning and he can't get out of bed. This is something different, and it's the fact that these things are sometimes not picked up, and the common story that people have had symptoms and they've been going on for several months before the penny drops and something else happens that makes the diagnosis. I mean, a compression fracture in a 40-year-old is not normal. And so to treat it just with analgesia and not say, well, why have you got a compression fracture at 40, is sort of something that is hard to understand. Height loss, that's over a period of time, obviously. Weakness and fatigue is a disproportionate thing. People who develop myeloma get this weakness. They get two things that come through. And then obviously you've got your anemia. Part of that's due to anemia. They get hypercalcemia, they get kidney stones, they get renal failure and acute problems there. But it's putting that together, and just some more signs and symptoms. And if you look at it, the most common ones are these ones at the bottom, where there's a calcium level in the blood that's high, renal insufficiency, because that's sometimes, people are managing the back pain, anemia, and bone disease. And trying to get this diagnosis, there we go, made early is something which I think is really important. The history that's common to all of the fractures and to the diagnosis, in my experience and what I'm seeing, is back pain with muscle spasms. A disc doesn't give you muscle spasms. It may do for 24, 48 hours, but as soon as you're on some form of anti-inflammatory or some form of analgesia, which is you can buy over the counter, generally speaking, it settles down. But it does, or if there is early muscle spasm, it disappears. Not so with myeloma. And these muscle spasms are really a common feature when people talk about it in that acute phase. And the severity of the pain is disproportionate to what they think has happened. All right? Hypercalcemia may be part of it, and that's possibly why we get the muscle spasms. It's certainly a contributory factor because tetanus is related to the elevated calcium. The weakness that goes with it, you pop a disc, you're not weak afterwards, but you're sore. But it's this, you've got the pain, but people are working, they're not getting much in the way of that. The pain is not relieved by rest. And often it's worse at night. It's worse when people are lying down. That's not fracture pain. It's not mechanical bone pain. And then it obviously lasts longer than is expected because if you pull your back or you pop a disc, 2 weeks of bed rest and analgesia, and most people, we're talking sort of 60 to 80%, will be up on their feet. They may still have some discomfort, but they're beginning to move around. Not so with myeloma. And so it is unique in that, but we wonder why it takes so long for the penny to drop. And I think it's difficult. So where do we start? All right, so it's sort of quite a good starting point if you look at pain and you look at stability, because both of these are affected in equal proportions in the early part of the disease. And for pain, we have opioids, we have gabapentin, we have bed rest, we have radiotherapy, and then we have targeted focal radiotherapy and SBRT. And for stability, what's the reason, the importance there? Well, it improves mobility, it improves the well-being, it improves social function, means you can come to these group things, you can still see your friends at home, and so on and so forth. And then we have augmentation, and that sort of ties into this stability part here. It must be said that radiation therapy is considered the standard of care for palliative pain relief in cancer. There can be other things you do, but that's the thing. So there's a filter in the system that is radiation therapy in terms of pain management. We're trying to shake these, but it's still in the book. All right. You can interrupt at any point, but I'll come back to it in a bit. So imaging is a key, all right, in terms of how do you investigate back pain. Well, before you do blood work, before you do anything else, you're probably going to have some form of imaging. And in primary care, family health, you might get an X-ray. They might send you for a lumbar spine. You've got lower back pain or upper back pain, you might go and get an X-ray done. X-rays are great, but they don't give you a lot of information. It's just the way we've changed. And with cross-sectional imaging, CT and MR, you suddenly are into a whole different, you get a whole lot more information that's available to you. And so the things that are key here are, is there a fracture? If there's a fracture and you're 40 years old, that can cause pain. If there's a fracture and you're 80 years old, that can cause pain. Trying to tie that to when the pain starts, when it doesn't start, that's part of the exercise. So if there was a point, getting out of a car, you twisted, you bent down to pick up something. One of the last patients was picking up some water, a case of bottled water in the store, and felt his back go. And he was in bed by the evening. But it's putting the story and things together. In Africa, everything is 2 weeks. How long have you had the pain? 2 weeks. When were you born? Before the last rain. The time reference is always important. So there we go. So imaging becomes really important. We have MR and we have CT. The two images on the left-hand side, the one with the white around the spinal cord, that's a T2 weighted image. The one in the middle is a T1 weighted image, and then on the right we have a CT. And these are actually the same patient. We've got slightly more on the MR, and I think my mouse, actually, yeah, I can point to this. Is it coming? Yeah. Is it coming across the screen? I can use it. No, maybe. It seems to be sometimes there. I can see it down here. But no, I can see it here, and it seems to be sometimes on the screen when I come across it. There, you see? When I move it, there we are. But it doesn't stay there. There it is. There it is. It seems to wait for the image. But all these white areas here in the vertebra, this is myeloma. This is acute myeloma, and these are myeloma cells, the plasma cells. And so these are the plasma cells that are in the bone, and you can see here in this obviously abnormal vertebra here how they sort of line up near the end of the vertebra, up near the top of the vertebra. And if you look at the levels above and below, you can see there's a bit of a collection of that. When we go to the T1, you'll hear these phrases in the reports and when you're reading the reports. The T1 doesn't show you water, all right? It shows you fat, which is the primary thing, and replacement of the fat signal. It's not going to do it. So replacement of the fat signal is marrow has a fat component in it, and so these areas like that are cells which don't have fat in them, myeloma cells. And that's what we use the two. So it's the combination of the two, and this is quite clearly a diffuse process, and it's most sort of typical of myeloma, and you would take it on to another stage. CT lets us see the bone. And yes, it's X-rays, but people get very scared of having X-rays, but you can see that there are big changes in the bone, and it can be done very easily in someone who's got a lot of pain and moving around. But what happens is, you can see where the bone is eroded. This is not, and the whiter areas are where the bone is sort of compacted, and that doesn't mean that that's stronger bone. That's the fracture. That's the bone just being pushed and compressed. That shows that. We can see higher up, we get that rim underneath the curve. They should all be square. They shouldn't be curved. And you talk about losing centimeters, losing inches in height. That's where it's going. So every vertebra is losing that little bit, and it gradually gets there. So that was acute disease. This is recurrent disease, and on the left we've got two vertebrae that have black holes in them, or black spaces in them. But looks like a fish in that middle one there, in L3, and that's cement from a previous kyphoplasty, and you can see that that's black across here and here, and around it you have, again, that white area underneath the edge of the bone. And that's where myeloma goes. And this is recurrent myeloma, and it has a more speckled appearance in the middle. It's hard, again, I think you might see it better from the room. But that's how we pick up a recurrence. And sometimes before you even have changes in the blood or before you've noticed anything else, you're getting changes on the imaging. And I'll pick it up and I'll contact the physician and say, is there a recurrence present? Why are we seeing this? And then they follow through on that. On CT, it was there briefly, and then it disappeared. If we look at the top left image, this is CT, and we see bone because we're now seeing the matrix of the bone, the calcified part of the bone. Right in the middle of the vertebral body, you can see a little gray area. Right? And that was in 2000 and that was on February the 25th, and then in December of the same year, you can see how that has grown in size. That's the plasmacytoma, that's the the myeloma has grown. Now, it may not have, it wasn't picked up in that initial image in terms of reporting, but that may have been, there may not be much more than that in the whole of a spine that's been imaged. There's a lot of other pathology. There's a spondylolisthesis, there's a slip of the vertebra, so there are other things that can cause pain, and not necessarily picking that up. We can see degenerate changes, but a lot of that painful lesion has become apparent over time, and that's another reason to it. At the same time, this is progression of disease, and so other lesions appeared over time, and we have lesions higher up in the spine, and we have a lesion in the humerus on the top left there. We can see at the top where the humeral head is. As we come down, there's a bit of moth-eaten bone, and then you come down to more normal-looking bone further down. That was the painful lesion. The patient was not complaining of a lot of change or a lot of discomfort in the spine because this was a dominant pain lesion. But we can see how there's a fracture mid-thoracic, and the vertebra, the bone of the vertebra has eroded, and we had a thing. So there's quite a progression in the 8 months to 10 months from February to December, and the patient hadn't been seen or wasn't apparently in care in that time. Patients complain about the sternum. What happens with the sternum? The sternum is being affected by myeloma. Myeloma is softening the bone. All right, so it's making the bone soft. And in that initial phase before it gets treated. What supports the spine at the back as it starts to curve like this is you've got a strut, you've got a support at the front. But if that's also affected and it fractures, you have a very rapid, sort of almost catastrophic effect that happens. The spine posteriorly collapses and does this. It flexes. And we've just had a case of that, and the patient was admitted to Princess Margaret in pain crisis because had been certainly painful, was being managed, and then the sternum fractured. Because it's supporting the spine, it fractured. So he had pain and at the back and at the front. Eventually has been managed, but unfortunately it happened very suddenly, and we weren't able to, the whole team wasn't able to do much in terms of getting the spine corrected in terms of that. Now, if we can catch it sooner, all right, we can prevent some of this. This is my personal mission in life. But we can still treat the spine, and there was an augmentation here. We can see that there's acrylic cement in the vertebra in that middle section there. There was a kyphoplasty performed at a couple of levels in addition to that. And the idea is that we can support that spine and prevent it from compressing down any further. And so the back part, the posterior part, is now being supported to an extent while the sternum will sort of heal and the bone will become stronger. And that's really why Prolia, zoledonic acid, the drugs that are being used to try and improve the bone come in, because they are there to try and improve the metabolism of the bone and to increase the strength of the bone again. And so it's multifactorial what we're doing. Okay. So again, we've got two things happening. We have a new fracture. We have a new fracture happening in the vertebra, and we have a sacral fracture here. Come back. And a sacral fracture, that's a year after being treated for the initial vertebroplasty here. So it's ongoing disease. If I see you once, there's a good chance I might see you again. But that's thing. All right. Why do patients get pain? There are lots of factors. The big one is you have a fracture. Radiation can treat cancer. Chemotherapy can treat cancer, but it can't treat a fracture. So if there's a fracture involved, there's almost always pain involved. And how that pain presents is really where some of, you've all experienced it, or most people who've had spine disease have experienced it. It's from that fracture. So why, when you have a fracture, and I'm hoping this is going to work. Where are we? There we go. Okay. If you look at this image here, and you look at one of the vertebrae right in the middle there, this is a real-time fluoroscopy image, and you look at this vertebra here, and you see what's happening there. It's doing that. Just with the patient lying on a table with normal respiration. Okay? Not forcing it, he's not being moved, he's not doing exercise, just with breathing. All right, we wonder why. He was excruciating pain, couldn't move. But this is his history. All right, he actually had it's part of the spectrum. He had amyloid, and so he was being managed. He's part of the hematology group. They were managing him for his amyloid, and he was getting the chemotherapy and so on. But this is the course of his sort of final 2 years. I saw him, and he presented with some fractures. He had a 7 out of 10 pain score. Treated him with kyphoplasty. Saw him at follow-up, and his pain was down at 2. He continued, he did fine, we didn't see him again for almost 1.5 years. And then he represented with another fracture, and again this time the pain was more severe. He knew what the fracture was, and that's often the case. The first time you have it, you try and, oh, well, I can put up with this, I can manage, I'm not quite sure what it is yet. The second time it happens, you're banging on my door. All right, can you fix me? And so, again, presented very quickly with that pain, and a month after the treatment, he was down at 1/10. No pain. But the time gets shorter because the bones, all of the bones are being affected. He also had something which wasn't responding in the same way as myeloma, but it's in that group. And then at about 6 months later, he presented with this fracture in the mid-thoracic spine, and that was where his pain. So it was 10/10, whether he was lying down, whether he was standing, whether he was sitting. And I think it took them 6 hours to drive from St. Catharines, where he lived, to Toronto on the day of the treatment. And he drove back with one stop for a pee break after the procedure, and he did very well. He ultimately, he did succumb to his disease a couple of months later, but he was pain-free. Yes?
Sorry, so you said he went from 10 out of 10 to driving himself back?
No, he can't drive. They're not allowed to drive back, but his wife was driving. But instead of stopping for every sort of, half hour, or every 20 minutes for a break on the way here, he drove back. They drove back with one stop. That's the impact of having the procedure, in terms of just taking away that mechanical component of the fracture. He was a lovely man. He and his wife, they were foster parents and had fostered for many years. Between the first and the second procedure, he had to sell his Harley Davidson. It was a big decision to make, but he kept it until he had the second fracture, and then he realized that he wasn't going to ride the bike again. So he did that. But as I say, it's a sort of long-term relationship. So then again, just another thing, just to show that CT complements MR. The MR is bottom right. You can see the myeloma, you can see the fracture, you can see the sort of edema in the bone with that, but you don't actually see the fracture itself, and you realize that the bone is completely disrupted there. So we don't need to dwell on this, but we have acute and chronic. The important thing about the chronic is that you get little punched out lesions in the bone. But you can see how on the right we've got a spine which is straight, and then we go and we start seeing a spine which is not straight in the lower one on the left. And that's what happens if untreated. I just put this in here because people always ask, should we have contrast? We don't use contrast to look at the spines with metastatic disease or with myeloma. We rely on the fact that the bone is replaced by something to see the lesions. And I don't know how easy it is for you to see, but the best vertebra here is this S1 vertebra, and you can see there are little black spots in there. There's a fracture up at this level, and there are little spots in the vertebra. But when you give contrast, gadolinium, they enhance, so they disappear, and you don't see them. So gadolinium and contrast is used for a different reason in the spine, and it's usually looking at the spinal cord or it's looking at something else. But the insistence of having contrast, and particularly if you go south of the border to have your scan down in Buffalo, you'll be charged for contrast, and you'll get contrast. Okay, so what are the indications for vertebral augmentation? Disabling pain due to fracture, diminished ambulatory capacity, prevention of collapse, poor surgical candidate, multi-level spinal disease, and comorbid illness. These guidelines date back to early days of augmentation. And they really help and they don't help, but pain has become this thing. So we're treating pain all the time. On the right, we have a patient that's been treated. This image is put there very specifically to show you that the spine in the treated segment is straight. And right at the top of it, right up the top there, it suddenly does this. And this is a patient, I won't say lost to follow-up, they were being adequately managed, but it wasn't appreciated that they were having more fractures because imaging was not part of that particular physician's, shall we say, repertoire. They managed them. And patients don't automatically get spine imaging to follow it. They were managing the pain. And I'm going to come back to that again. I've mentioned it several times.
How often do hospitals require or request CT or MRIs at the
It really, I mean, that... how often do doctors get imaging of the spine? It's really what while they're managing. That's very variable, and it depends on local sort of folklore, because there's a belief that imaging is hard to get. It's a belief. It's not a reality, because it's always available. It's there for cancer, and it's there when you want it and need it for cancer. And this idea that you can't get a scan is really it's a bit of mythology. But patients may go for a year, 2 years without having a scan. Often it's because they're not symptomatic. All right, now's probably the best time to bring it in. Myeloma patients are unique in one thing. They don't complain of pain. Okay? They manage pain, and it's part of your culture. You can have horrible disease, you can have acute fractures, but you get yourself in a lazy boy, and you take the opioids, and you take your gabapentin, and you don't move, and you barely breathe, and you sit there. And when you say to somebody, have you got pain? No, I don't have pain. Because that's what you're doing. And so you say, all right, and particularly when it was a telephone consultation through COVID, well, you don't need very much, can't do much for you because you don't have pain. And even when I'm saying you, as a collective group, come in, you say, well, I don't really have pain, I don't have much pain. You don't have much pain because you're managing it well, and your culture says, if I can keep that pain down and I don't do anything, I don't need anything. Well, you don't know that you don't need anything done, but the people that you're talking to are saying, you don't have pain, so therefore I don't have anything that's saying that you need to have anything done. And it drives me mad, because one of my colleagues is so focused on pain as being the trigger for it. You know, I think patients are denied care that they should be. It's just my position. But it's really important to realize that people have something more than pain that they manage. They have what's called life. And if you're not going to the shops, if you're not taking a walk down the street, if you're not going to your neighbors to see them, and they're just coming to visit you because you don't want to move from your lazy boy, you're not part of that social fabric. That's really important for state of mind, for all sorts of good things. It's a positive thing that you're actually interacting with other people. And that is what augmentation gives you. You can manage the pain, but you're taking a big dose of opioids. You're taking other stuff that makes you feel funny, but you're sort of managing. But I'm okay, but I'm not doing anything. And you say, but what were you doing before the diagnosis? Well, I would have been out mowing the lawn today. I would have been doing something else. That's what we need to get you back to. And that belief that you can be better than you don't have to accept the fact that it's not. Everybody has marrow in their spine, and it's one of the last places that the marrow sort of stops being prolific. It gradually gets less and less over time. But that's why it's very, very affects myeloma goes to the spine. It goes to the pelvis, it goes to the spine, and it goes to long bones. Long bones lose it first, but the spine and the pelvis keep it for quite a long time. I can't keep talking till there you are, you're back. Now I can change slide, you see. There was a reason for it keeping talking. So this is the work that I started. I started with cancer care in 2014, and I sort of spearheaded the project, and we eventually got the OTAC, which is the Ontario Health Technology Advisory Committee, to make a recommendation, and they made a recommendation to cancer care and to the public about vertebral augmentation. They couldn't separate out vertebroplasty or kyphoplasty. There are minor differences, but in terms of pain, but they said it should be publicly funded and it should be made accessible for patients. There we go. There we go. And not only that, but it put cancer care very right in there, right at the front, and said that, yes, we're going to fund it, but you're going to govern it, and you're going to draw up the guidelines and say why it should be used or how it should be used, and determine the thing. There's a difference in cost between a vertebroplasty and a kyphoplasty, and it's just in product that's used. Companies will make things that you can use all the time, but it comes at a cost. And when you're in a public health system, they want to go for the lowest cost option all the time. Doesn't mean that the higher cost option is better, but you have to have those options available to you if you need them. So I keep going from back to front. So there we go. So this is the sort of the committee and the group that I worked with. And this is where we come down to acute painful fractures that should be treated within 6 weeks. We're talking acute fractures. We're not letting that fracture collapse down like this. The thing about vertebra is it's a little short, fat, dumpy bone. And if it fractures, it doesn't wobble, it doesn't do this. It goes like this, all right? And the more you walk on it, the more it squashes down. And so it's painful. And it's the only fracture in the body we tell everybody to keep walking around on. All right? Symptomatic fractures with load bearing and or axial tenderness. That's what we call mechanical pain. When you're up and walking around, you've got pain. When you sit down, it goes away. When you lie down, it goes down to 0. That's mechanical pain. It gets worse if you're standing on your feet. Okay? It's managed, it can be managed, but that's a symptomatic fracture. High-risk impending fractures due to a lytic lesion. So you've got a tumor that's in the bone, it dissolves the bone, there is no bone. As you treat the tumor, the bone has nothing to support it, and it will collapse down. Same with myeloma, same with other metastatic tumors. And then it's either collapsed because of that, or there's a high risk of it going to collapse. And if it's a high risk of it going to collapse, the risk that also exists is if it collapses suddenly, does it collapse suddenly and just cause pain, or does it collapse suddenly and cause stuff to be pushed around and cause neurologic damage and deficit? And you end up with a paraplegia or paraparetic patient. It's very hard to get neurology back. You can get bone back, but you can't get if the nerves are damaged. And then this spinal instability neoplastic score is really an indication when you're looking at imaging, and it's a way we communicate between oncology and imaging, that shows you a degree of risk, a degree of instability. And if you track spines over time, the SIN score will increase with a tumor that's dissolving the bone. And so the idea is to try and intervene before something catastrophic happens. Okay, so then that was for any augmentation procedure. Then kyphoplasty, because it involves some devices usually, for acute compression fractures, fractures with a gas-filled cleft. That's a fracture that's not going to heal. The bone is dissolved, there's movement, it's not going to heal. And using a kyphoplasty device will stabilize that fracture. And then, obviously, with soft tissue tumor and absent cortex. So the guidelines were very clearly defined. It splits it 60-30, 2/3, 1/3, and the expensive procedures are the 1/3. And then, in order to sort of validate that, the importance is through an MCC, a Multidisciplinary Cancer Care Conference, and this is the foundation of a lot of cancer care in Ontario. The authors of the project are at the bottom there, but really what they say is, this is a tumor board. This should be a multidisciplinary decision process. Yes, we're not necessarily an expert in that field, but we're acting as a moderating influence, so that you should be able to get the option. It is. We cheat. We call them vertebra. But only because there's no. I mean, it's it's just the structure. It's really to get the hospitals paid. There's a physician fee for everything that's done in medicine, but it's really because there's money that comes to the hospital, and that's specific money. So. It replaces, it allows staffing, it allows replacement of equipment and that sort of thing. That's really what it does. But these are the sort of the criteria that would have to be discussed. If they're complex cases, the expectation is it would be presented, and so you have oncology, medical oncology, radiation oncology, surgeons, and the interventionists that do the procedures, discussing it in a common forum and making a plan of therapy and treatment. And that's really what the MCC is about. And they either endorse it or they don't, but it may be that it's more appropriate to have a surgical procedure than an interventional procedure. It's really looking at, is the spine stable enough to do a minimally invasive procedure. It's all right doing something, but if part of the vertebra has been damaged, it may not be there enough, stable enough to support that. Okay, we can talk on for hours. All right, contraindications, instability. epidural compression, in other words, there's something in the spinal canal, whether it's soft tissue tumor or bone fragments. This third one is one that I have personal issues, personal things about, unable to localize the painful level. And the traditional way of evaluating a patient and assessing a patient was to examine them, press on the bone, press on the spine, see if they could say, okay, where is your pain? This is clearly the fractured vertebra, and treat that vertebra if they could establish it. If you can't do that, then it's a contraindication to doing a procedure in the sort of the concept of treating pain. Radicular pain, that means you've got pain there's narrowing of the foramen, or there's something pressing on the nerve and the pain maybe going down the sciatica is radicular pain. Is that a contraindication? No, it's not a contraindication if there's a disease process there, but it's not necessarily going to be improved by the procedure. You will be treating the fracture, you might be treating the collapse, and the hope would be that because you've got less movement happening or less compression on that nerve, that you might get some improvement in that pain. It's not a primary endpoint. You can treat the pain in a different way if you've got stability back in the spine. And then obviously the medical contraindications. But localizing the level is important. I just run my hand down the back and I tell me, stop me when it's at the level you feel the pain. And it's usually between here and here. And that's very accurate because people know where it is. But if I press on the vertebra, it doesn't always elicit pain. And that's still in the books. Okay. What does okay, here we go. So this is what we do in terms of augmentation. Okay. So this is a kyphoplasty. All right. So we put some needles in. We then, through those needles, we put some balloons into the vertebra, and we inflate the balloons, just like that. Lifts the vertebra up, supports the vertebra, and then we inject some cement into that space that's created, pretty much follows that space, and we do it. And that's the end result, that we have support. This is all cancer, by the way, that's sitting out here around the side, but we haven't gone back into this part here, which is where the spinal cord is. So it can be done very safely in vertebra.
How long does a procedure like that take?
If it's just the one level like this, somewhere between half an hour and an hour. It's not a long procedure. Am I running over time? Okay. Complications. These are pretty much standard. I was going to say, they're in the little booklet, the brochure that we give out, but it's really cement extravasation. Everybody talks about leakage. Do you have leakage or not? The leakage, any leakage that's there, happens during the procedure. It doesn't go. It stops us doing any more to it, but it's very rarely does it come with symptoms. Might come with some radicular pain. It irritates a nerve root. So they're fairly self-explanatory. Okay, so we're just going to go through the kyphoplasty pictures again. All right, so balloon kyphoplasty. This is really the reason. This is what the whole thing to get funding for. There's the needle. We put some cannulae into the side of the vertebra. We then do the military trick of lifting things up, and there's the balloons, and you can see that we actually get good height restoration in the middle part. It comes up quite nicely, and we can hold the vertebra. There are some advantages to oh, it doesn't like that. It does that again. It goes backwards. Oh, what's going on? There we go. fracture reduction, height restoration, it immobilizes it, and you get pain relief. So you can get very good pain relief very quickly in some of these, but it can take anything up to about 2 weeks to get the real benefit from a procedure. The more vertebra that I treat, the longer it will take. So if I treat 6 or 7 vertebrae at a time, then it will take anything up.
Are those balloons inserted into the vertebrae or between the vertebrae?
Into the vertebra. They compact the bone and lift it up. They don't stay there. They come out. They come out. We put cement into the space. So on the left here, these vertebrae, you can see all the little black holes in them. That's chronic disease. Those holes stay there forever. They don't go away. If you have X-rays, they will always be there. If you have MRs, they will always be there. That's what we were talking about. Some of the questions were about being on zoledonic acid, being on various things. It's to maintain the strength of the bone that's around the holes, rather than trying to correct it. But the difficulty when you have a lot of disease like that is, what do we do to make that decision? Where's the acute fracture? Where's the one that's causing the problem? And that I think can be quite difficult. There are 2 ways of dealing with it. One is to do what we call a stir sequence. It's an MR sequence, and it shows us the edema in an acute fracture, and that's a really important thing. Or the other thing, or the other area that approach to it is where I've sort of moved to, and that is, I think of the spine in terms of segments, and I think of it in terms of if it's at the thoracolumbar junction between the thoracic and the lumbar spine. And so we're talking T11, T12, L1, L2. If you have a fracture there, or 1 or 2 fractures, or some height loss in more than 1 vertebra, I treat them all. I treat all of them because that's a mobile section of the spine. And if you treat them, you get a good result. If you leave it, you may get a good result. You may have got the right one. That's usually, I mean, we usually get the right one, but you get a much better functional result for treating the segment than just treating sort of an individual vertebra. One of my colleagues, and I think that's sort of the approach. So this is a case we did this week. The vertebroplasty, you can see the needle comes in from down the pedicle of the vertebra into the body. It's at T12 on the left. You look at it from the side, it's positioned in that part of the vertebra there. Did this over multiple vertebrae, they all had fractures, and you can see the one in the middle here. This one was probably the reason that the person was hospitalized in pain crisis, because the vertebra has essentially been dissolved by myeloma in that. But by treating all of them, we've treated all the fractures that were there. Where are we going? There we go. All right. Just sometimes it's necessary to use 2 needles. It's just a way of controlling the cement. But most of the time we can get away with just 1 needle. You were talking about the pelvis and other parts of the body. If you look at the left, you can see the work that I did in this pelvis here. This is somebody who had been in hospital for 3 months, so deconditioned that was unable to stand, unable to walk. The CT scan, the image on the left is with the patient face down. The image in the middle is the patient on their back. So the area that's missing is here. Okay? And that's where the cement is. You can flip the image around. And so this was done over several procedures, 2 or 3 procedures, to rebuild that part of the sacrum that had been dissolved by the myeloma. He wasn't running marathons, but he was up and walking within a month in rehab from that, following it. So this is what it looks like on the table. using the X-ray machine to guide us. And this is multi-level. You can count the 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 needles there. And the X-ray shows what we're doing when we inject it. Okay. Again, treating multiple levels. There's multiple disease. This would have been an acute fracture, perhaps another acute fracture, and you can see that the rest of the spine has multiple levels of fracturing. And this is where talking about what are people doing, what is life like, becomes more important than do you have acute pain. They're managing their pain, but they're not doing anything. And this is what the mission is to try and treat. I'm a bit of an outlier, I do admit, but we're trying to gather the patients and get them written up so that we can actually put this message out. The story is there. It's very easy to follow, and I think that treat them all. Patient has 2 weeks of a bad back, doesn't feel very well because of it being done, but they are cancer patients. Okay. So let's go back. What do I do? There we go. How have I got? Okay, so how do I get back? I'm trying to go backwards. Okay. This is just to say that not everything is done sort of in a single shot. So I thought this was quite cute. In 3 bites over 9 months. So the MR on the left just shows the fracture. We can see where the disease is. There's a myeloma lesion in the vertebra here in the sacrum. We've got the changes in the iliac bones. Very, very common to have it in the iliac bones. We place 2 needles across the sacroiliac joint. Whoops. I have 2 needles across the sacroiliac joint, and we've modified the technique to make it safer, and hopefully, as other physicians, they're getting very interested in doing sacroplasties, but it's for them it's a bit harum scarum because it's different to doing a vertebroplasty. The difference in cement volume, we can using 27-30 ml of cement in a sacrum, where you're only using up to about 3 in a vertebra. So it's a big difference in how it works. But we use multiple needles. On the left is the first procedure. Then the patient came back with iliac pain. And so iliac crest pain, the iliac bone has lots of muscles. It has your gluteal muscles, your butt muscles. It has other muscles attached to it. So walking and moving and bending and exercising becomes very painful. And so the second procedure is the one on the right there. You can see that put 3 needles in place, and we've then tried to cover that with sort of a cement framework. And then the final procedure, they were still complaining of pain, and this is over a period of time, and it never quite got away, but it always came back to just that, what people call their hips, but it's really just the top of the iliac crest here. And we then, you can see how we filled that iliac crest, and it's fanned out in this. Is it going to? No, it's not. You can see where the cement went, and it's following the bone there. So that was 3 procedures, and she's now pain-free. I mean, it's relative, but she's pain-free in terms of being able to sit, being able to get out of a chair, being able to walk. And I think, now this is a quiz, all right? Not quite, but this is a 62-year-old man. He's just this is the sort of history we get in terms of what type of myeloma, what stage they are. Reported to have a compression fracture 2 years ago and has had back pain since. He's got worsening of back pain. He's got costal margin pain, scapular pain, weight loss, and loss of appetite. Sorry. Okay, no neurologic complications, and he's on a fairly big dose hydromorphone. So he's taking 18 milligrams twice a day, and he's taking, we never know how much breakthrough, but he's on 4 milligram tablets there. Abnormal bone marrow, so he's got multiple fractures, 7, 10, 12, L1, L3, L4, and he's got no cord compromise. This is traditional, where they take x-rays, they can show there's some fractures. There's the skull, they're looking for punched out lesions, and there's his MR. Okay, so this was his initial MR in 2013. I think they were just making the diagnosis, 2013. And he was then imaged a whole year later. This is his next imaging, and he's got progressive change at that thoracolumbar junction.
Would these be active metastatic lesions, or are these old lesions, or does it matter? Would you be approaching it differently?
If the diagnosis has been made, and they're sort of on induction, or they're being treated, then you have to say that they're treated lesions. The bone has gone; it's not coming back, but they're being treated. If they haven't made the diagnosis, they're active lesions. So when is the diagnosis? In terms of, when do they? That's in that spectrum of time, and it's not uncommon to have a patient that's a year later comes back in, and they've only made the diagnosis a year later, with this sort of picture. But you've gone from a spine with just a little bit of a curve. This is the thoracolumbar junction just up here. All right, so we've got a fracture there, but you can see the holes in the vertebra. They don't go away. And when we look here, that's collapsed further, that one's collapsed further, this one's collapsed further. And those vertebrae, they don't come back. You can't restore any height to them. You can put cement in them, which helps with a lot of, it helps usually with sitting pain and rest pain, and it helps with movement. But you may not get a huge benefit over, in terms of activity. So he was then started that. He's still having ongoing back pain, but you can see that his hydromorphone requirements have increased over time, and it was only a year to a year and a half later that he actually had treatment. And immediately after treatment, this is usually within a week, he's already down to a quarter of the dosage of his hydromorphone. And I mean, this is just a snapshot in time, so I can't tell you where he is now. He may be. And this would be a procedure, this would take about an hour and 20 minutes to do. So it doesn't look pretty, but those vertebrae are now stabilized in terms of cementoplasty. So the questions are, and this is the message that we're trying to get and communicate. When do you consider kyphoplasty? When should it be? How early? When does it happen? Can it be done concurrently with radiation therapy, chemotherapy? The answer to that is a categorical yes. If you have radiation today, I can treat you tomorrow, and there's no complication associated with having had radiation. If you want surgery, you're looking at 3 months after radiation, because of the effects on the tissues from the radiation. So it's something that, as being interventional using a needle-driven technique and image-guided, that allows us to interact. So chemo today, treat tomorrow, treat this morning, chemo this afternoon, type of approach to it. It really depends on how a patient feels. And this is the message. People they've not considered that anything can be done for them very often. You've got lots of information, lots of literature, but it's there's a huge process that's happening. It's coming to terms with having a cancer diagnosis. It's coming to terms with immobility. You're reading all the literature. It's telling you how bad things are going to be, when in fact that's the moment where we can actually make the biggest difference in terms of trying to prevent. This is when you talk about preventative treatment. is in this window. It's having that window at least shown to you and opened. You making the decisions. If you're not up to it, if you don't want to do it right now, that's okay. But that's the message. So that's the part that one is talking about in terms of preventing something from happening that will affect an individual 1 year, 2 years, 3 years, 10 years down the line. And how many levels can be done at the same time? And this is where, obviously, I differ from some, but my colleagues that I work with, they are, and that was a 62-year-old man, all right, that was there. They understand. It's, again, when you see it and when you see how patients are, you realize that it's been good. But there's almost nothing in the literature. We've just grown to that over time, and because they're cancer patients or you've got an active disease process, you try and do maximum therapy safely at the initial phase. So here's another example, all right? These are just talking points. 64-year-old man, it's pretty much the same story, but a 12-month history of recurrent back pain, weeks of bilateral lower leg numbness, he's had urinary urgency, difficulty with peeing, some constipation. The question is that due to neurologic dysfunction? Is it due to the fact that they're on opioids, they're on some form of something that's causing a lot of that? They've numbness from T7 down. This is when they presented, hip flexor weakness with normal rectal tone. So they're not paraplegic yet, but they've got neurologic compression. This was a scan. Oopsie, there we go. There we are. That shows that there's a, whoops, doesn't like you hovering over the images. But we can see that there's a soft tissue tumor in the T7 vertebra. It's going backwards from that line that you see down the back of the vertebra. So it's in the spinal canal. We can see how much of the vertebral body has been dissolved by this tumor. It's been eaten away, and there's already some compression there. Now, as that compresses and it comes down like that, it has to push something out of the way. And that's where we talk about this sort of potentially catastrophic event can happen. And you can cause paraplegia at that point. Okay. So they went a different route. So they had within 2 days, that was a presentation. So 2 days, within the next 2 days, they had see, it really doesn't, I've got to be careful I don't hover. If I stay down at the bottom there, they had a surgical procedure. They had a decompression, instrumented fusion, and that's cement with a pin that's sitting in there in the middle. So that was in 2016 when they presented. Okay, so the patients are still around, obviously, but that was a different approach. And this is why multidisciplinary treatment. Could we have done something different if they'd come into a combined clinic, if they presented in a slightly different way? Because myeloma is very responsive to radiation therapy, it's very responsive to chemotherapy. Almost to the point that surgery is a sledgehammer to crack a nut, where it could have been done with a planned approach, monitoring it. But they've had the surgery, and that's what happens if you present with cord compression. The cord will be an attempt to decompress it. So how long does it take for nerve function to return? It may not from the spinal cord. It might if it's peripheral nerve, if the nerve, once they're exiting the spinal canal, they may recover. But you can have quite long-term effects on the cord. And that's really the time from when they suddenly became paraparetic to presentation. The longer that period is, the less likely to get return. Time frame, recovery beyond which the nerve function is unlikely to return if it is not. I think if you're getting to 2 years out, you're not going to get much neurologic function back. You're going to see maximum in the first 3 months, 6 months, up to a year. but then it starts as you go further out, you're going to see less. And then of course there's this big question: peripheral neuropathy and residual nerve damage. It's usually fairly straightforward. Peripheral neuropathy is miserable for the people that get peripheral neuropathy. Can be really, really distressing, but it's like wearing a pair of socks, wearing a pair of gloves, and the discomfort that goes with it. Whereas nerve damage tends not to be symmetrical. Much harder to have symmetrical changes. Yes?
Regarding the cement that you place, question is, do you expect any erosion over time, or is it stable for good?
We had a question earlier about that a little bit, but no, the cement will be there forever. The bone, there are two things that can happen. One is if a kyphoplasty is done and a balloon has compacted a space, made a space, and it's used to allow the cement to be injected safely when there may be very little bone to support it. That's one scenario. Or it's there to elevate a fracture. What it does do is it pushes bone cells together. You push bone cells together, they like it, and so they will lay down more bone. So there's a positive benefit in terms of bone metabolism. You can get bone laid down as a result of that. Not dissolving, it can actually strengthen the bone for doing it. If you're not filling the space, nothing is an empty space inside the body. As long as if it's supporting, it won't weaken. You don't get erosion of bone really over time. You can get tumor that can erode bone, but it's not the cement that's causing it. It's complicated in some of it, but we see people who come back after 6, 7, 8 years, and some of the bone has perhaps dissolved around about, but they're not symptomatic through that. But it's more, it's just occasional examples. It's more related to the fact that you're now 78, 79, as opposed to being 69, 70. There's an age factor, and that's related to the bone. Okay, this is another example here. Look at the white in the sacrum, and then the iliac bones. There's the T1, and you can see the grey. We look at this image on the left over here. We can see we've got some black spots. That's previous augmentation of cement in those vertebrae. We've got white vertebrae there. This is recurrence. This is recurrent disease. And this is the story. It was recurrence with new MRI activity. Corresponding to the MR activity, there was blood activity and there was pain. So there was symptomatic activity going on, MRI activity showing really extensive disease and pain. The first, and yet that's 8 years from the initial vertebroplasty, and nothing in between. Okay, so in that bit before the individual and the physician that they presented with radiculopathy, ended up with a surgical procedure where they had a decompression of the S1 nerve root over here. The pain didn't go away. But anyway, but you see, people present in different ways, and so this chap who was in a centre far remote from us here, although I treated him, still within Ontario, but went to a surgeon with radiculopathy and ended up having a decompression. Where in fact, had he gone to, sorry, where are we? There we go. So then he came, did this, he was pain-free, he was on a plane a week later and in another country for a period of time. Myeloma, it goes to the sacrum. It really goes to the sacrum in a lot of people. We can do lots of things with sacroplasty. Okay, plasmacytoma, that's just where it's all collected into one. It's named as a plasmacytoma. It's a tumor of plasma cells, which are myeloma cells, rather than it being diffuse and multiple centered. There it is in the sacrum. It's been treated. It's more like a blob in the middle of the sacrum. Again, at the end of it, it's pain-free. Oops, go back. How do I get it back? The other way, this way. Okay, so we do try and correct it. This was a little too scary for people to do, but it gives a very nice picture at the end of it. We developed this concept. It supports the sacrum beautifully, but most people don't have the fortitude to do it because it, as I say, it's a bit different putting a needle that's this big across someone and then injecting the cement. So we've modified that. That's why I say we're working all the time to try and make it safer and more acceptable to people. And then coming to, very briefly, I'm going to put a picture in here. This is the most I'm going to say. This is the multidisciplinary metastatic spine clinic. It's a brand new clinic. It's on the UHN website. It's on their front page if you go looking for clinics. And it's been the collaboration and conversation and a lot of talking over about the last 5-6 years to do this. When I took over the spine service in 2007, the average length of time from referral to being seen in consultation was 3 months. From being seen to being treated was another 3 months. That's how long it is. Now, from referral for consultation to treatment, we can actually have that down to 2 weeks or 3 weeks. And we're looking at, thank you. Again, not perfect, but that involves oncology, it involves surgical consultation, it involves all of the team, and we now have pain physicians tied into the clinic as well. So it's a whole team that will see a patient on a single day when they come in as necessary. So it does mean you might be there for a couple of hours, might be longer, but it ends up as being a treatment plan, and it's integrated management. And this is out of the star with the S in the brackets is because the surgeons like to think about it as stability. They like to put stability into it. The oncologists don't want the stability, and they think it scares people away because it might be surgical. But that's the idea, and we've come a long way. It's not perfect. It's finding its way. So now it's question time. Thank you.
Dr. Smith, you mentioned earlier something about publication issues related to the website patient ratios. Was there a publication you specifically referred to? You looked over here.
No, we published that technique, but we've published sacroplasty just recently. We've got a second paper coming out on sacroplasty, on the revised technique and on the results there. Myeloma is about 40%. It was 44%, but it's come down a little bit. It's being diluted by other cancers, but almost half of the patients that come through that clinic are myeloma patients at various stages. So it's a big group that are coming through, and we're working with data all the time, and it's trying to get the data processed and into publication, because that's the way. Ultimately, that's where you see changes happening outside of here. I mean, we can change people, we can do things, but in order to, it's an academic center, so in order to further that, we collect data. So if you get phone calls from people saying, how do you feel, what did you think? It's usually somebody endorsed, they're not trying to sell something or scam you. Yes.
We talked about being a myeloma patient and being very careful about your exercise program, so you don't cause a fracture. So if someone doesn't have any diseases at this point, what would you advise? So for example, to golf or whatever?
Right. That's a fabulous question. I don't know if everyone heard it. It's about advice regarding exercise and being told that you mustn't do anything to cause a fracture. And I think that comes into this mindset that myeloma patients have, that they don't do anything, but they're relatively pain-free. They're not doing anything, but they're being safe. The Osteoporosis Society, who sort of have similar things that they say, there are pages and pages and pages and pages and pages online, and I think there are like 5 web pages how to get out of a car without causing an injury. And there's not one word about vertebral augmentation in the osteoporosis sort of website in terms of it, because they don't think about it. They're internal medicine, they're physicians, and they don't think procedurally, and yet it works very well. In myeloma and in cancer, if you have something that you really want to do, discuss it, and there's absolutely no reason why you can't do it afterwards. The idea is to try and get you fit enough for that. So first thing is pain, second thing is a degree of stability, and we can do all of that. And then there are some exercises, but patients that are passionate on golf, they go back to golf. We get them back to golf. We may do it through physiotherapy. I think there are limitations, and the first one is had a patient who kept coming back because he was so excited that he didn't have pain. He went out, mowed the lawn, and came back in with 2 new fractures at different levels. But it's the sort of that enthusiasm because you're pain-free suddenly, and you've got and the stability and the feeling of stability that comes from multi-level augmentation is terrific, from what I'm told. It's like going from feeling wobbly to suddenly being able to walk down the street without doing this. And I think that's something, again, it's something that you see when you're treating people. And with a group of patients as a mass, that is not in the literature. You will find nothing in the literature about balance and stability after augmentation. But if you are in the general sort of rehab world, if you break your ankle and you go into rehab and you're being rehabbed with physiotherapy and what have you, the last thing to come back is proprioception. And proprioception is that internal sensation of knowing where you are. It's the closing your eyes and putting the finger on the end of your nose. That's proprioception that determines that. You know, you start out here with your eyes closed and it comes right in onto the end of your nose. If you broke your arm, I'm not saying that would necessarily be it, but you might not feel it until it's healed. But it's the idea that balance is coming through your body, and that's when they put you on these half Boson balls and they start making you stand and get your balance back with a broken ankle. And it's really tough to get it back with things. That happens in the spine. And it happens in the spine, but something happens when you do an augmentation that you get that sensation back, and patients will say, I can stand straighter, but I'd like to play golf. Is it okay if I play golf? Yes, but let's just take it slowly. Don't, your game may change. If you want to play tennis, if you think you can, get yourself fit enough to do it. Don't just rush out and do it. And I think that's what's really important about doing these procedures. Core strengthening is far better, and that's something you can do. Walking is great, just walking. But, be careful about the weight that you pick up. A 2-kilo bag of flour or sugar up on a shelf, bringing it down, you've got 2 arms and a bag of sugar. That's quite a lot of weight, and that's on your back. When you travel, When you put your suitcase on that thing at the airport, get someone else to help lift it off when it comes flying past you. You know, when you're on a holiday and they have these boat trips and you're going out through the waves, think about either taking a cushion or it's not something to do, because the fractures happen because of that sudden movement. But it's not. But these are all just examples of what happens when people come in with the fractures. But there's almost no. I don't put any restrictions on what people do. But I think the message is you want to be fit enough to do that. And the first thing is pain. If we can get you out of pain, we can get you into that feeling better and feeling movement, and you start walking, then you can start thinking about the next things. And physiotherapy are really good at that, at helping in that, when you get to that point.
Is there any other quick questions?
How soon after someone gets diagnosed with multiple myeloma do you expect to see these type of spinal conditions present?
They might be there at diagnosis. I mean, it's in the bone. So if it's already eroding the bone, the holes in the bone are there. Now the actual bone damage can be very extensive at time of diagnosis, or it can be minimal, or it may be multifocal. So you've got it in several vertebrae, but some of them are more affected than others. I mean, you'll have it'd be erosion in the skull, but you don't necessarily feel that. But it's because it's a bone-centered disease. That varies.
You like that 40% figure comes to mind. I'm not sure your slide suggested that sometimes the bones, I guess, nearby, if you're doing that, might lead to problems. So I guess my question would be, is there a particular part of the bird? Obviously, treatment earlier is, I would guess, better than waiting. But also, is there a certain part of the spine that's more susceptible and more dangerous to deal with? My guess would be the upper part of
the mobile parts of the spine are so that thoracolumbar junction is very vulnerable. The majority of fractures will happen at that level. The upper part of the spine, I can treat up to about T2. So that's just below the neck, and that can be done very easily. I say it can be done very easily. It can be done very safely up to that level. It's not as easy when you get up into that for technical reasons. But that's the sort of limit. Above that, even if people have fractures and even if they have disease up there, it tends not to be as symptomatic. The only thing it's holding up really is the head, the spine. I mean, there's enough weight in that, but it tends not to be as symptomatic. So we don't normally treat people when they're getting there. But T2, T3 is about the upper limit. But if I can treat them up to that level early on, then I can keep that part of the spine straight. But that's the part of the spine that will do this if you're not managed. Now, people talk about bracing. Does bracing help? It only helps if you're in that really, really, really acute phase, right at the beginning, where you saw the image with lots of fluffy white stuff in the bone is soft, you put someone into a Jewett brace, because that's how you have to wear it. And you have to wear it for as long as it takes to get that disease under control. You might be like that. And the problem with it is it's really uncomfortable. It has to be put on. You have to take it off to go to the bathroom. You have to put it back on. And all sorts of things that go with one of these braces. So does that help to keep the spine straight? Yes, it probably does, but it's the application of that principle, of that process. I'm not a brace supporter because most people don't wear them properly.
Dr. Smith, thank you so much for a wonderful presentation.
Thank you.
What you have done for myeloma patients in the background is incredible. Thank you for spending your Saturday afternoon from your family and developing these slides. And with that in mind, to present you with a gift of glass. With our utmost appreciation.
Thank you. Thank you very much.